Hello, this is Emergency Care and Transportation of the Sick and Injured, Chapter 16, Cardiovascular Emergencies. Cardiovascular disease accounts for about 1 out of every 3 deaths. Depending on the year, it can flip-flop with cancer, but more years than not, heart disease is the #1 killer of adults in the United States. EMS can help reduce deaths by providing the following services: encouragement of people to follow a healthy lifestyle, early access to medical care, more CPR training of lay people, and increased use of involving technologies in dispatch and cardiac arrest response. You also have public access to defibrillation devices and recognition of the need for advanced life services. Okay, the anatomy and physiology of the heart and circulatory system is very important that you understand this thoroughly and completely, given the fact that 1 out of every 3 adults dies of coronary problems. It is extremely important that you are very aware of exactly how this system works. And your foundation for the various systems that we're studying up closely, like the respiratory system that we just completed, the reason Chapter 6 is so crucial is that is your foundation from which the expanded detail of individually crucial systems are built upon begins in Chapter 6. So please make sure that you have a solid grasp on anatomy and physiology so that when we study respiratory system, and in this case a circulatory system, so that it clicks into place and you're able to build on what you learned in Chapter 6. So here we go. Anatomy and physiology of the circulatory system. The heart's job is to pump blood and supply oxygen-enriched red blood cells to all tissues of the body. The heart is divided down the middle into left and right sides, and each side has an atrium on the top, and this receives incoming blood, and a lower chamber, which is the ventricle, to pump outgoing blood. Now, there's a little more to that, and we are definitely going to cover that. This slide illustrates the heart, and please remember that you are looking at the heart. So when it says, for instance, left pulmonary artery, that is the anatomical reference. So that it might be on the right side of the slide, but that is the left side of the heart. Just like the patient's side is opposite yours when you're face to face with them. So bear that in mind when you're looking at these illustrations. And if I say something is on the right side of a slide or the left side of a slide, I'm referring to the slide itself, not the physical structure of the heart as you are facing it. Please make sure that you are completely knowledgeable about the terms that are on this slide, because everything you're about to cover is based at the very beginning from a structural standpoint on this slide. Now, the blood leaves each of the 4 chambers of the heart through one-way valves, and these keep the blood moving through the circulatory system in the proper direction. So each of these valves is a one-way valve, and that prevents backflow from pressure within the system itself, so that it keeps blood moving in the one-way direction intended. The aorta is the body's main artery, and it receives blood ejected from the left ventricle and delivers it through all other arteries that supply the body's tissues. We're going to talk a little more about that in detail. Now, this figure on this slide illustrates how blood circulates through the heart. On slide A, which is your left slide, or the left illustration on this slide, the right side of the heart receives oxygen-poor blood from the venous circulation, and the arrows show you where the blood is, the direction that this is carried through the heart. Okay, so this figure on the left side of the slide, again, illustrates how blood is received from the heart, oxygen-poor blood from the veins, and is circulated through the heart. And this is the oxygen-poor blood. And the figure on the right side of the slide is the left side of the heart, showing how oxygen-rich blood runs from the lungs through the pulmonary veins. You must know the structures illustrated on these slides as well. Now, the heart's electrical system controls the heart rate and coordinates the work of the atria and ventricles. We talked about terminology. This is one of those that you must be clear on. The plural of atrium is not atriums. The plural of atrium is atria. So please pay close attention to your medical terms. We covered that in a previous chapter. And make sure that you know them correctly so you're able to notate things properly, take exams now and in the future, and you are well aware of singular and plural, etc. So I just wanted to throw that in there because I hear atriums a lot and it's really frustrating. So make sure you remember at least this one tip, but it applies to all medical terminology. So again, the heart's electrical system controls the heart rate and coordinates the work of the atria and ventricles. The heart generates its own electrical impulse starting at the sinus node, which we're going to talk about in just a moment. This impulse passes from the atria to the ventricles, and this automatically allows spontaneous contraction without a stimulus from a nerve source. So in other words, the electrical impulse that's generated in the sinus node is generated right there in the heart and is meant only to travel through the heart. So it's not being that impulse that travels completely through the heart and completes its own circuit is not fired from the brain and spinal cords. So the SA node that generates the electrical impulse within the heart itself only is very important for you to understand that that is only for the heart, generated by the heart specifically. And so as long as the impulses come from this node, the sinoatrial node, the other myocardial cells will contract when that impulse reaches them. If no impulse arrives, the other myocardial cells are capable of creating their own impulses and stimulating a contraction. And that's an important thing for you to understand, and we will cover in more detail coming down the road. So just to recap this slide again, I wanted to offer some extra explanation so that it's clear, but I'm going to just recap it. The heart's electrical system controls heart rate and coordinates the work of the atria and ventricles. The heart generates its own electrical impulse starting at the sinus node or sinoatrial node, and this impulse passes from the atria to the ventricles, and this automatically allows spontaneous contraction without a stimulus from an outside nerve, one of the spinal nerves. Okay, so again, this is the electrical impulse that's generated in the heart itself from the SA node, and then that impulse follows a bunch of nerves through the heart itself. So that impulse is generated at the SA node, travels through the electrical system of the heart itself. Now on this slide you see the structures of the electrical conduction system of the heart. So if you look at the left-hand side of your slide, upper left-hand slide portion of the slide on the illustration here, you see the SA node, and that's that sinoatrial node that I was talking about that generates the electrical impulse, which then follows this pathway of conduction inside the heart itself. You must know the names of each of these structures, where they're located, and specifically what they do. Now, the autonomic nervous system controls involuntary activities of the body, and if you recall, that is situated in the brain stem. The autonomic nervous system has two parts which normally balance one another. You have the sympathetic nervous system, which is the fight or flight system, and this you have no control over whatsoever, but it is sympathetic in that its sympathetic nerves react to messages received from the brain. So again, the ANS, autonomic nervous system, has two parts which normally balance one another. The first is the sympathetic nervous system, which is called the fight or flight system because automatically heart rate increases, breathing increases, pupils dilate, all the things needed for you to flee, for instance, if you were being preyed upon, just from our evolutionary past. Okay, so that's the fight or flight system. You have no control over it. And it again speeds up the heart rate, increases respiratory rate and depth, dilates blood vessels in the muscles themselves, and constricts blood vessels in the digestive system. In times of stress, this system takes control. The parasympathetic nervous system slows heart and respiratory rates, constricts blood vessels in the muscles, and dilates blood vessels in the digestive system. In times of relaxation, this is the system that takes control. So, for instance, if you were to be horribly frightened, I hope that never happens, but if you're horribly frightened, the sympathetic nervous system kicks in. That's your fight or flight system, speeds up heart rate, increases respiratory rate and depth, dilates blood vessels in the muscle, and constricts blood vessels in the digestive system. In times of stress, this is the system that takes control. Now, the parasympathetic nervous system, let's say you got frightened and then you realized everything's okay. Now the parasympathetic nervous system takes hold. It slows the heart and respiratory rates down, constricts blood vessels in the muscles, and dilates blood vessels in the digestive system. In times of relaxation, this is the system that takes control. The myocardium must have a continuous supply of oxygen and nutrients to pump blood. Increased oxygen demand during periods of physical exertion is supplied by the dilation or widening of the coronary arteries. Stroke volume describes the volume of blood ejected with each ventricular contraction. Increased stroke volume results in increased cardiac output. Increased stroke volume results in increased cardiac output. The coronary arteries are the great blood vessels that supply blood to the heart muscle. They start at the first part of the aorta, just above the aortic valve. The right coronary artery supplies blood to the right atrium and right ventricle, and in most people, the inferior wall of the left ventricle. The left coronary artery supplies blood to the left atrium and left ventricle and divides into two major branches just a short distance from the aorta. The figure on this slide illustrates how the coronary arteries carry the blood supply to the heart. You must know these structures on each of these illustrations on this slide. And remember, the anterior view is when you're looking at the heart onto the front of the heart. The posterior view is the back side of the heart if it's facing away from you. The arteries supply oxygenated blood to different parts of the body. The right and left carotid arteries supply the head and brain. The right and left subclavian articles supply the upper extremities. The brachial arteries supplies the arms. The radial and ulnar arteries supply the lower arms and hands. The right and left iliac arteries supply the groin, pelvis, and legs. The right and left femoral arteries supply the legs. The anterior and posterior tibial and peroneal arteries supply the lower legs and feet. The arterioles and capillaries are smaller vessels that receive blood from the arteries. Capillaries are 1 cell thick, so extremely fine. And these capillaries exchange nutrients and oxygens for waste at the cellular level. And the reason they're so thin is so that exchange takes place by the form of gases breathed in and out. Now these capillaries also connect arterioles to venules. The venules and veins receive blood from the capillaries, and venules are the smallest branches of the veins. The vena cava return this oxygen-poor blood to the heart. So remember the gas exchange taking place, as was discussed in the respiratory system, in the alveoli, and the alveoli are just, there are billions of capillaries in there, and they're 1 cell thick, so they take in oxygen from the lungs, and the oxygen and carbon dioxide are passed in and out of the body through these 1 cell thick capillaries. Okay, so just to recap what I said on this slide overall, because it's very important that you understand it. The arterioles and capillaries are smaller vessels that receive blood from the arteries. The capillaries are 1 cell thick. These exchange nutrients and oxygen for waste at the cellular level, and then they connect the arterioles to venules. The venules and veins receive blood from the capillaries, and the venules are the smallest branch of the veins. Vena cava is the large vessel that returns oxygen-poor blood gathered up through the venules and veins back to the heart. And the superior or upper vena cava carries the blood from the head and arms back to the heart. So you have the superior vena cava that brings waste products from the brain and upper part of the body above the heart. That's the superior vena cava. The inferior vena cava is drawing all the waste products from the veins from the lower part of the body below the heart. And each of these carry it from the top and from below back to the heart. The blood consists of several types of cells and fluid. Red blood cells carry oxygen and remove carbon dioxide. White blood cells fight infection, and platelets help blood to clot. And plasma is the liquid or fluid that cells float in. That's your red blood cells, white blood cells, and platelets. They're all transported via plasma. Blood pressure is the force of circulating blood against artery walls. The systolic blood pressure is the maximum pressure generated in the arms and legs during contraction of the left ventricle during the time period known as systole. The top number in the blood pressure reading is the systolic blood pressure. Diastolic blood pressure is the pressure against the artery walls when the left ventricle relaxes. The bottom number in a blood pressure reading is the diastolic. So again, the systolic pressure is when the left ventricle contracts, and blood pressure, it's the amount of force against the artery walls when the left ventricle contracts, and that is systole and produces a systolic blood pressure, and that's the top number of the blood pressure reading. Diastolic blood pressure is the pressure against the artery walls when the left ventricle relaxes. This bottom number is the diastolic reading. A pulse is felt when blood passes through an artery during systole. So that period of maximum pressure is boom, when you feel that pulse. Peripheral pulses are felt in the extremities, such as the radial and posterior and tibial. The peripheral pulse is felt in the extremities, such as the radial and posterior tibial pulse. Central pulses are felt near the trunk or body, such as the femoral and carotid. Another example of a peripheral pulse would be in the wrist. That's your radial pulse, just to clarify that for you. So again, peripheral pulses are in the extremities, central pulses are near the trunk of the body. The figures on this slide demonstrate the common pulse points. A is the carotid pulse point. Those are the carotid arteries that take oxygen-rich blood up to the brain. The femoral artery is the large artery on the inside of the groin that carries oxygen-rich blood to the extremities. The brachial pulse is the artery that feeds the arms, and it's on the inside of the upper arm just below the bicep, and it runs parallel with the humerus. The radial is right in the wrist. You have the posterior tibial that I talked about before. This is the illustration of where that is. And the dorsalis pedis, which is on the top of the foot, and you can check the pulse there as well. Cardiac output is defined as the volume of blood that passes through the heart in 1 minute. It's calculated by multiplying the heart rate by the volume of blood ejected with each contraction, or stroke volume. Let me repeat that. Cardiac output is defined as the volume of blood that passes through the heart in 1 minute. It is calculated by multiplying the heart rate by the volume of blood ejected with each contraction, or stroke volume. In the field, stroke volume can be roughly determined by the heart rate and strength of a patient's pulse. So that's what you're doing when you checking pulse, is measuring cardiac output essentially. Perfusion describes the constant flow of oxygenated blood to the tissues, and good perfusion requires the following: A well-functioning heart, and with that goes an appropriate heart rate that allows proper volume of blood to be circulated, an adequate volume of fluid or blood, and the reduced volume of which, through hemorrhage, would limit the amount of tissue that can be perfused effectively. Blood vessels must be appropriately constricted to match the volume of blood available. Dilated blood vessels mean reduced perfusion. If perfusion fails, cellular death occurs, and eventually the patient will die. Now, the pathophysiology for the cardiac system is what we're going to discuss now. Heart-related chest pain usually stems from ischemia, which is a decreased blood flow to the heart or inefficient supply of oxygen and nutrients. This ischemic heart disease involves a decrease in blood flow to one or more portions of the heart muscle. If the blood flow is not restored, that tissue will die. Atherosclerosis is a disorder in which calcium and cholesterol can build up and form a plaque inside the walls of blood vessels. It can cause complete occlusion or blockage of a coronary artery and other arteries of the body. Fatty material accumulates as a person ages, resulting in the narrowing of the lumen, which is the inside diameter of the artery. In other words, the inside opening of the artery. And this inner wall of the artery becomes rough and brittle. If brittle plaque develops a crack for unknown reasons, we don't understand exactly this process completely, but if brittle plaque that has built up develops a crack, the ragged edge of the crack activates the blood clotting system. So platelets will pile on there, and this results in a blood clot that will partially or completely block the lumen or inside opening of the artery. And this slide gives you an illustration of what I just explained. And it is worth noting that older patients might refer to themselves as having arteriosclerosis versus atherosclerosis. Arteriosclerosis is the old term for the same thing. So if a patient tells you they have, an older patient says they have arteriosclerosis, you're going to know that to be an actual fact, what is now known today as atherosclerosis. It's the same thing, it was just renamed. A thromboembolism is a blood clot that floats through blood vessels. If it reaches an arrow too narrow for it to pass, it will stop and block blood flow at that point. Tissues downstream from that blood clot will then suffer from hypoxia. And if too much time is passed, or too much time goes by before blood flow is resumed, those tissues that aren't receiving past the point of blood clot will die. This sequence of events is known as acute myocardial infarction, and it's a classic heart attack. Infarction means tissue death. The death of heart muscle can severely diminish the heart's ability to pump and lead to cardiac arrest. In the United States, coronary artery disease is the #1 cause of death for men and women. The peak incidence of heart disease is between 45 to 64 years, but it can strike in individuals ranging from their teens into their 90s. Risk factors place a person at higher risk for a myocardial infarction, also known as AMI. Major controllable risk factors are cigarette smoking, high blood pressure, elevated cholesterol level, elevated blood glucose level, which is diabetes, and lack of exercise and obesity. Major uncontrollable risk factors are older age, family history of atherosclerotic coronary artery disease, race, ethnicity, and the male sex. Unfortunately, men are slightly more likely to have coronary artery disease than women. Acute coronary syndrome describes a group of symptoms caused by a myocardial ischemia. This includes temporary myocardial ischemia resulting in angina or angina pectoris, or a more serious condition, which is an AMI or myocardial infarction. I pronounce angina. That's how I was taught in pre-med anatomy and physiology, but it is pronounced and is correct, pronounced both ways. So if you hear me say angina, I mean angina. You can pronounce it either way, it is correct. So just to recap what's on this slide, I just wanted to point that out to you. So I'm not saying it incorrectly, I'm just saying it one of two correct ways of saying angina or angina. So to recap what's on this slide, acute coronary syndrome, or ACS, describes a group of symptoms caused by myocardial ischemia. This includes temporary myocardial ischemia, which results in angina pectoris, or can be a more serious condition, which is myocardial infarction. Angina pectoris occurs when the heart's need for oxygen exceeds the available supply, usually during physical or emotional stress. It can result from a spasm of an artery, but is most often a symptom of atherosclerotic coronary artery disease. It may be triggered by a large meal or sudden fear. When increased oxygen demand goes away, the pain typically goes away. Angina pain is commonly described as crushing, squeezing, or quote-unquote like someone standing on my chest. It's usually felt in the mid portion of the chest under the sternum and can radiate to the jaw, arms, frequently the left arm, but not always the left arm, mid-back, or epigastrum, which is the upper middle region of the abdomen. It usually can last from 3 to 8 minutes, but rarely longer than 15 minutes. It may be associated with shortness of breath, nausea, or sweating, and usually disappears promptly with rest, supplemental oxygen, and nitroglycerin. And although angina does not usually lead to death or permanent heart damage, it is a warning sign that should be taken seriously. For instance, if you have a patient who, upon arrival, when you're taking their history, they tell you that they're having these kinds of pains and that they have angina, and it usually goes away if they might say, if I rest, take some nitroglycerin, usually goes away in about 10 minutes. But the reason that you've shown up at their door is none of these things is working, perhaps, and they might be headed towards myocardial infarction. So angina should never be dismissed lightly, and there are mitigating circumstances such as an extremely long duration that would cause you to address this as an emergency. But anytime a patient with angina is having these symptoms, you must take them seriously. Unstable angina occurs in response to fewer stimuli than is ordinarily required to produce classic angina. Stable angina responds to rest or nitroglycerin, and this will be covered in Skill Drill 16-1. Patients experiencing chest pain or discomfort should always be treated as if they are having myocardial infarction. The pain of myocardial infarction signals the actual death of cells in the area of the heart where blood flow is obstructed. Once dead, the cells cannot be revived. They will turn to scar tissue and become a burden to the remainder of the heart that's beating. About 30 minutes after blood flow is cut off, some heart muscles begin to die. After about 2 hours, as many as half of the cells in the area may be dead. After 4 to 6 hours, more than 90% of the cells will be dead. Opening the coronary artery with either, let me say that one more time. Opening the coronary artery with either clot-busting, thrombolytic drugs, or angioplasty, which is mechanical clearing of the artery, can prevent permanent damage if it is done within the first few hours after the onset of symptoms. So immediate transport is essential. Myocardial infarction is more likely to occur in the left ventricle, and signs and symptoms of AMI, or myocardial infarction, include the following: sudden onset of weakness, nausea, and sweating, chest pain, discomfort, or pressure that is often crushing or squeezing that does not change with each breath, pain, discomfort, or pressure in the lower jaw, arms, back, abdomen, or neck, irregular heartbeat and syncope or fainting, shortness of breath, which is dyspnea, nausea and vomiting, pink frothy sputum, and sudden death. And from this point forward, I'm going to refer to myocardial infarction as AMI unless I am specifically differentiating it from similar terminology. So AMI will now be what is used to refer to when discussing myocardial infarction. The pain of AMI differs from the pain of angina in 3 ways. It may or may not be caused by exertion and can occur at any time, sometimes when a person is sitting quietly or even sleeping. It does not resolve in a few minutes, rather can last between 30 minutes and several hours, and it may or may not be relieved by rest or nitroglycerin. Not all patients who are having an AMI experience pain or even recognize when it occurs. When called to a scene where the chief complaint is chest pain, complete a thorough assessment no matter what the patient says. You should always complete a thorough assessment. So the patient says, I'm having a heart attack, They may well be, and time is of the essence, but you need to make sure you complete an assessment, as there may be other mitigating circumstances. Physical findings of AMI and cardiac compromise include the following: general appearance of the patient, where they may appear frightened, may have nausea, vomiting, and cold sweat, pale or ashen gray skin, or cyanosis. In regards to their pulse, the pulse rate increases in response to pain, stress, fear, or injury to the myocardium. They may have irregularity or slowing pulse or bradycardia due to damage of the inferior area of the heart. Their blood pressure may fall due to diminished cardiac output and left ventricle function. Most AMI patients will have a normal or even possibly an elevated blood pressure. It depends on where the damage occurs in the heart, as we just talked about. Most AMI patients will have a normal or possibly elevated blood pressure, as we just discussed. And as far as respirations, it is usually normal, but if the patient has congestive heart failure, or CHF, they may be rapid and labored breaths with a higher likelihood of cyanosis and possibly frothy sputum. Their mental status may be confused. They may have agitation or overwhelming feelings of impending doom, such as, quote unquote, I think I'm going to die. An AMI can have 3 serious consequences. A, obviously sudden death. B, cardiogenic shock. C, congestive heart failure. Dysrhythmia describes an abnormality of the heart rhythm. Premature ventricular contractions are extra beats in a damaged ventricle. They're harmless and common among healthy as well as sick people. Tachycardia describes the rapid beating of the heart at 100 beats per minute or more. Bradycardia describes unusually slow beating of the heart at 60 beats a minute or less. Ventricular tachycardia describes a very rapid heart rhythm at 150 to 200 beats per minute. It may deteriorate into ventricular fibrillation, and ventricular fibrillation describes disorganized, ineffective quavering of ventricles. When this happens, there's no blood being pumped through the body, and the patient usually becomes unconscious within seconds. Defibrillation may convert this arrhythmia and put them back into, hopefully, a normal rhythm, normal sinus rhythm. Defibrillation is the process of shocking the heart with a specialized electrical current to restore its normal cardiac rhythms. It can save lives if the shocks are delivered within the first few minutes of sudden death. CPR must be initiated until a defibrillator is available. Chances of survival diminish approximately 10% each minute until defibrillation is accomplished. Asystole is the absence of all heart activity, usually reflects a long period of ischemia, and nearly all patients with asystole will die. Asystole is also known in the vernacular as flatline. In other words, there's just no electrical activity at all. So that is asystole or flatline. And just to go back and touch on a couple of small things and review something I said right at the beginning. Defibrillation is the process of shocking the heart with a specialized electrical current to restore its normal cardiac rhythms. It can save lives if shocks are delivered within the first few minutes of sudden death, and CPR must be initiated until a defibrillator is available, and chances of survival diminish approximately 10% each minute until defibrillation is accomplished. And as I mentioned, asystole, which is absence of all electrical activity. And the reason I went back is to illustrate this one thing. CPR must be initiated until a defibrillator is available. However, chances of survival diminish approximately 10% each minute until defibrillation is accomplished. So CPR is continuing delivering oxygen to the brain and tissues of the body. However, CPR will not restore heart rhythm. So defibrillation is key. You aren't going to restart the heart if it has no beat or it is a wildly out of control, ineffective beat. CPR is only going to keep oxygen moving through the body. Only defibrillation will help restore as close to a near or hopefully a normal sinus rhythm. And just to remind you also, now you know where the term sinus rhythm comes from. The electrical impulse that goes through the heart itself and is responsible for causing the heart's atria and ventricles to contract and drive blood through the heart itself, that's initiated at that SA or sinoatrial node, and that is where the term sinus rhythm comes from. So now you know, and you have a full and complete understanding of that now. Now, cardiogenic shock occurs when body tissues do not get enough oxygen, causing body organs to malfunction. It is often caused by a heart attack, and the heart simply lacks the power to force enough blood through the circulatory system, so the entire organism collapses. It is more common in an AMI affecting the inferior and posterior regions of the left ventricle. So in other words, cardiogenic shock is more common in AMI if it's affected the inferior and posterior regions of the left ventricle. It is important to recognize shock in its early stages. Shock is caused by many things, but cardiogenic shock is caused by what I just described. Now, shock, no matter what its causes, shock is shock and must be treated immediately, and it's crucial to recognize this shock in its early stages. Congestive heart failure, or CHF, often occurs within the first few days after a myocardial infarction. CHF develops when increased heart rate and enlargement of the left ventricle no longer make up for decreased heart function overall. And this is due to diseased heart valves or chronic hypertension. So let me say that one more time. CHF develops when increased heart rate and enlargement of the left ventricle no longer make up for decreased heart function. It is called congestive because the lungs become congested with fluid, which is pulmonary edema, once the heart fails to pump effectively. It can occur suddenly or slowly over months. In acute onset CSF, severe pulmonary edema is accompanied by pink frothy sputum and severe dyspnea. This fluid may also collect in other parts of the body, which is called dependent edema, such as in the feet or legs. So someone with a history of heart disease that, for instance, if you have a patient who presents with a history of heart disease and has swelling in the feet and legs, you can recognize that as signs and symptoms of CHF, or congestive heart failure. Hypertensive emergencies involve any systolic blood pressure greater than 100 millimeters of mercury or a rapid increase in the systolic pressure. Sudden severe headache is a common sign. Other symptoms include the following: strong bounding pulse, ringing in the ears. So those are hypertensive emergencies. In other words, their blood pressure has gotten way too high. You can also have, with hypertensive emergencies, nausea and vomiting, dizziness, warm skin, and it can either be dry or moist, but it's going to be warm, nosebleed, altered mental status, and sudden development of pulmonary edema, which, as you know, we just talked about it, produces pink frothy sputum. Untreated hypertensive emergencies can lead to stroke or even a dissecting aortic aneurysm. Transport patients to the hospital as quickly and safely as possible. Consider ALS assistance here, because depending on your transport distance and time, they have drugs and more advanced equipment for this type of situation. Aortic aneurysm describes a weakness in the wall of the aorta. It is very susceptible to rupture. If it ruptures, blood loss will cause the patient to die almost immediately. A dissecting aneurysm occurs when the inner layers of the aorta become separated, allowing blood to flow at high pressure between those layers. Uncontrolled hypertension is the primary cause. So sometimes you'll have a patient who says that they have high blood pressure, and you ask them what they take for it, and they say nothing. Take that and run with it. Get them to the hospital right away. It's not the time to judge or question their motives, whatever they may be. Simply recognize that they're in trouble. Your job is to get them to the hospital right away, but it is key that you note some situation like that. It's only one example that I gave you. Make sure you note that. But aortic aneurysm can result from one cause being uncontrolled hypertension. The table on this slide lists the differences in pain presentation between AMI, or myocardial infarction, versus aortic aneurysm. So make sure that you review this slide so that you're able to recognize the differences in pain presentation between the two. Continuing with aortic aneurysm, their signs and symptoms may include the following: very sudden chest pain located in the anterior part of the chest or in the back between the shoulder blades. The pain usually comes on full force from 1 minute to the next. And sometimes there is a difference in blood pressure between the arms or diminished pulses in the lower extremities. So you may have blood pressure readings and pulses recorded in the upper extremities that are very different than what you find in the lower extremities. You must transport these patients to the hospital as quickly and safely as possible. Now, with assessment, we're going to review these steps again. With patient assessment, remember the first step always is scene size up. Ensure that the scene is safe and safe for you, your partner, your patient, and any bystanders. This also determines the necessary standard precautions and whether you will need additional resources. You, in your size up, need to determine the nature of illness, the NOI, as we learned in an earlier chapter, and then use this information from the dispatcher, clues at the scene, and comments of family members and bystanders as part of your scene size up and determinations. In your primary assessment, you, if you recall, are forming your general impression of the patient. If the patient is unresponsive and not breathing, begin CPR starting with chest compressions and call for an AED. Assess the patient's airway and breathing. If there has been an incidence of dizziness or fainting due to cardiac compromise, then consider the possibility of spinal injury from a fall. Assess their breathing also to determine whether the ailing heart is receiving adequate oxygen. Now, as far as assessing their breathing, you may have shortness of breath with no signs of full-blown respiratory distress. However, if oxygen saturation with this shortness of breath is less than 95%, administer oxygen at 4 liters per minute via nasal cannula. If they do not improve quickly, then discard the cannula and apply oxygen with a non-rebreathing mask at 15 liters per minute. Now, if you discover that they have respirations where they're either not breathing or they have inadequate breathing, then you're going to apply 100% oxygen with a BVM or bag valve mask. If they have pulmonary edema, you're going to use positive pressure ventilation with a BVM or continuous positive airway pressure, which is CPAP. In your assessment, when you're assessing the patient's circulation, you want to note the pulse rate and quality of that circulation, and then look at their skin color, moisture, and temperature of their skin, capillary refill time, and then consider treatment for cardiogenic shock early to reduce the workload of the heart. Make sure to position the patient in a comfortable position, which is usually sitting up and well supported. Then you must make a transport decision based on whether you were able to stabilize life threats during the primary assessment. The remainder of the assessment can be performed en route if time allows. Most patients with chest pain should be transported immediately, obviously. Follow your local protocols for determining what receiving facility is most appropriate, such as the nearest facility or a medical center with spatial capabilities. Then you need to determine whether to use lights and siren for each patient, partially based on transport time. As a general rule, patients with cardiac problems should be transported in the most gentle, stress-relieving manner possible. However, it depends on the level of cardiac emergency you're discussing here. If it's a cardiac problem and they're very stable, you don't want to add more stress by, with lights and sirens wailing. However, the greater the emergency, the more volume and lights you need. So, now history taking, this is very important. When you're investigating the chief complaint, so you're taking their history, you investigate the chief complaint, and because patients experiencing AMI will have different signs and symptoms, seriously consider all complaints of chest pain or discomfort, shortness of breath, and dizziness. If the patient is experiencing dyspnea, is it due to exertion or is it related to the patient's position? Ask yourself. So let me just start from the beginning and recap this. This is really important. When you're doing your history taking and investigating the chief complaint, make sure to remember that because patients experiencing AMI will have differing signs and symptoms, in other words, no two patients are alike, seriously consider all complaints of chest pain or discomfort, shortness of breath, and dizziness. Now, if the patient is experiencing dyspnea, ask yourself, is it due to exertion or is it related to the patient's position? Is this continuous or does it change, like with deep breathing? If the patient has a cough, does it produce sputum? Does the patient have nausea, vomiting, fatigue, headache, and or palpitations? Make sure to ask yourself that. Ask about recent trauma. Obtain sample history from patients who are responsive and able to answer your questions. And ask the following questions. If you're suspecting AMI, have you ever had a heart attack? Have you ever been told that you have heart problems? Do you have any risk factors for coronary artery disease? In addition, make sure to ask what allergies does the patient have and what drugs or medication the patient is taking, and if they're taking it, what condition are they taking it for? Are they taking over-the-counter medications or home remedies such as various herbs, etc.? Include the OPQRST questions when obtaining symptoms as part of the sample history. Using OPQRST helps you to understand the details of specific complaints, and this is illustrated on table 16-2. So please make sure you look at it. That's an important table. And here is that table. This is the table 16-2, and it displays the OPQRST mnemonic for assessing pain. Please take the time to not just read this, but really learn it. With secondary assessment, focus on the cardiac and respiratory systems. You need to look at their circulation and assess their pulses at various locations. So don't just take a radial pulse. Take a radial pulse, a carotid pulse, perhaps a pedal pulse. So, check their pulses at various locations through the body so you can measure how they are in, relative to each other. Look at skin color, skin temperature, skin condition. With respirations, are the lung sounds clear? Are lung sounds clear? Are the breath sounds equal? Do they have distended neck veins? And is there any sign that the trachea is deviated, or is it sitting midline? Then make sure to measure and record the patient's vital signs. Okay. Once you have measured the pulses against each other, now just take a regular pulse and record it. Look at, measure their respirations. This is all the vital signs, pulse, respirations, and then take systolic and diastolic blood pressures in both arms. You want to make sure that they match or are extremely close. If available, use pulse oximetry. If there's continuous blood pressure monitoring available, use it as well. Repeat at appropriate intervals and note the time that each set of vital signs is taken and recorded. In patients with chest pain, it is very valuable to have a 12-lead ECG, also known as EKG, tracing from as early as possible after the onset of pain. EMTs may assist with the placement of electrodes. With the reassessment, repeat the primary assessment by checking to see whether or not the patient's chief complaint and condition have improved or are deteriorating. Reassess vital signs at least every 5 minutes or any time significant changes in the patient's condition occur. Sudden cardiac arrest is always a risk with patients experiencing a cardiovascular emergency. If cardiac arrest occurs, then if this cardiac arrest occurs and an AED is immediately available, make sure to use it. If not, perform CPR immediately until an AED is available. Then reassess your interventions, provide transport if not performed already, and with communication and documentation, make sure to call ahead and alert the emergency department about the patient's condition and estimate time of arrival. Follow any instructions that medical control may give you when you call the ER or hospital, and then document your assessment and treatment of the patient, and document everything and thoroughly using correct terminology. It's crucial because this is a patient where they don't have time to go through and they can't figure out what you've written down because you're using incorrect abbreviations or your terminology is not exactly right. So earlier when I was talking about how important it is to be accurate, this is one of the reasons why. When you're dealing with a situation where time is of the essence, you want to make sure that everything that you've assessed and treated is done so thoroughly and clearly so that it can be read quickly by attending staff. Now, emergency medical care for chest pain or discomfort continued here. Let's talk about ensuring that there is a proper position of comfort for the patient. So Allow patients to sit up if that's the most comfortable position for them. It is easier for them to breathe if they're sitting up. So usually they're going to want to sit up rather than lie flat. Make sure to loosen any tight clothing. Give oxygen if indicated, and continually reassess oxygen saturation and the patient's respiratory status. Use nasal cannula for patients with mild dyspnea. Use non-rebreathing masks for patients with more serious respiratory difficulty. Titrate the oxygen to obtain an oxygen saturation between 95 to 99%. Assist unconscious patients with breathing as well as those with obvious respiratory distress by use of BVM or positive pressure ventilation device according to your local protocols. Depending on your local protocol, prepare to administer low-dose aspirin and assist with prescribed nitroglycerin. Make sure to remember that an unconscious patient cannot be administered aspirin or nitroglycerin tablets because of danger of aspiration into the lungs or possible occlusion or partial occlusion of the airway. Now let's discuss aspirin. The effects of aspirin are that it prevents blood clots from forming or getting bigger if they already have blood clots. The dose is 81 milligram chewable tablets. The recommended dose for chest pain patients is recommended dose of 162 milligrams, which is 2 tablets, to 324 milligrams, which is 4 tablets. Again, know your local protocols and know whether or not you're authorized to administer this. With nitroglycerin, the available forms are sublingual pill, sublingual spray, and a skin patch applied to the chest that the patient wears for continuous release of nitroglycerin. Mechanisms of actions. Okay, the action that nitroglycerin produces is it relaxes the blood vessel wall muscles, increases blood flow and oxygen supply to the heart, decreases the overall workload of the heart, and dilates the blood vessels. Side effects of nitroglycerin is that it can cause a severe headache and may cause a change in the patient's pulse, such as tachycardia or bradycardia. Contraindications for nitroglycerin are if you administer nitroglycerin and the systolic blood pressure of the patient is less than 100 milligrams of mercury, do not administer more. Note whether there is a presence of head injury. If there is, do not give nitroglycerin. If there is use of erectile dysfunction drug within the past 24 to 48 hours, do not give nitroglycerin. They are wildly contraindicated. Also, if the patient has achieved maximum prescribed dose already, which is usually 3 doses, do not give any more. As far as administering nitroglycerin, make sure the medication has not expired or is not contaminated before administering it to the patient. Make sure prescription medications are the ones prescribed for the patient. In other words, this is medication they already have. You want to make sure it's not expired, it's not contaminated, and that if Jane Smith is the name on the bottle, that Jane Smith is your patient as well. Make sure to wear gloves when administering nitroglycerin because it can be absorbed through your skin. And then you will be able to follow these steps and practice them in skill drills 16-1. With cardiac monitoring, for an EKG or an ECG, I'm old school, I tend to say EKG. For ECG to be reliable and useful, the electrodes must be placed in consistent positions on every patient. So if you place them on patient A, they must be placed the same position on B, C, and D so that you're getting consistent readings between patients. And you know this because your electrodes are all in the same place, so there's nothing that can cause variable in readings between patients. So certain basic principles must be followed to achieve best skin contact and minimize any artifact in the signal itself. Artifact refers to ECG tracing that is the result of interference, such as patient movement, rather than the heart's electrical activity. Some guiding principles are that it may be occasionally necessary to shave body hair from the electrode site. Rub the electrode site briskly with an alcohol swab before application of the electrode to remove oils and dead tissues from the surface of the skin. Attach the electrodes to the ECG cables before placement. Confirm that the appropriate electrode is now attached to the cable and placed at the correct location on the patient's chest or limbs. Let me repeat that. Confirm that the appropriate electrode is now attached to the correct cable and that is then placed at the correct location on the patient's chest or limbs. This figure on this slide illustrates correct placement of ECG electrodes. Left side is the anterior view, and the right side is the anterior view with the electrodes placed properly. Once all electrodes are in place, switch on the computer, print a sample rhythm strip. If the strip shows any artifact, verify that the electrodes are firmly applied to the skin and the monitor cable is plugged in correctly. Then you will follow all of these steps for practice in Skill Drill 16-2. Heart surgeries and cardiac assistive devices is what we're going to discuss now. Over the last 30 years, hundreds of thousands of open heart operations have been performed to bypass damaged segments of coronary arteries in the heart. In a coronary artery bypass graft, a blood vessel from the chest or leg is sewn directly from the aorta to a coronary artery beyond the point of obstruction. Percutaneous transluminal coronary angioplasty. People typically just refer to it as angioplasty for obvious reasons, but percutaneous transluminal coronary angioplasty involves the following steps. A tiny balloon is attached to the end of a long, thin tube. The tube is threaded into the narrowed coronary artery and then inflated. The balloon is then deflated and the tube and balloon are removed. Sometimes a stent is left behind in the artery to maintain the opening on the inside, the lumen. Patients who have had bypass procedure may or may not have a long scar on the chest, but treat chest pain in a patient who's had any of these procedures in the same way you would treat chest pain in patients who have not had heart surgery. Some patients have cardiac pacemakers. Pacemakers help maintain a regular cardiac rhythm and rate. They're inserted when the electrical system of the heart is so damaged it cannot function properly on its own. These battery-powered devices deliver an electrical impulse through wires that are in direct contact with the myocardium of the heart. The generating unit typically resembles a silver dollar and is usually placed under a heavy muscle or fold of skin in the left upper portion of the chest. EMTs normally do not need to be concerned about problems with pacemakers. When they do not function properly, pacemakers can cause a patient to experience syncope, dizziness, or weakness due to an excessively slow heart rate. The pulse will ordinarily be less than 60 beats per minute. A patient with a malfunctioning pacemaker should be promptly transported to the emergency department. When an AED is not used, the patches should not be placed directly over the pacemaker. Let me correct myself there. When an AED is in use, do not place the patch from the AED directly over the pacemaker. Place it to the side of the pacemaker as close to normal position as possible. Now, we just discussed pacemakers. The other device that's typically implanted into the chest is an automatic defibrillator. Automatic implantable cardiac defibrillators are sometimes used by patients who have survived cardiac arrest due to ventricular fibrillation. These devices continuously monitor the heart rhythm and deliver shocks as needed. Treat these patients like all other patients having an AMI, including performing CPR and using an AED if the patient goes into cardiac arrest. The electricity from an automatic implantable cardiac defibrillator is so low it will have no effect on rescuers. External defibrillator vest is a vest with built-in monitoring electrodes and defibrillation pads, which is worn by the patient under his or her clothing. The vest is attached to a monitor worn on a belt or hung from a shoulder strap. This device uses high energy shocks similar to an AED, so you should avoid contact with the patient if the device warns that it is about to deliver a shock. The vest should remain in place while CPR is being performed unless it interferes with compressions. If it is necessary to remove this vest, simply remove the battery from the monitor and then remove the vest. Another type of device is the left ventricular assist device, also referred to as an LVAD. These devices are used to enhance the pumping of the left ventricle in patients with severe heart failure or in patients who need a temporary boost due to an MI. It may be pulsatile or continuous. The patient or family may be able to tell you more about the device, especially as it relates to your patient. Unless the device malfunctions, you should not have to deal with it at all. Contact medical control if there's any doubt in what to do. Transport all LVAD supplies and battery packs with the patient. Cardiac arrest is the complete cessation of cardiac activity, electrical, mechanical, or both. It is indicated in the field by the absence of carotid pulse. Cardiac arrest was almost always terminal until the advent of CPR and external defibrillation in the 1960s. Automated external defibrillation involves the use of small computer, which is an automated external defibrillator or AED, that is used to analyze electrical signals from the heart. It identifies ventricular fibrillation and is extremely accurate. It administers a shock to the heart when needed. AEDs come in different models. All models require some operator interaction, such as applying the pads or turning on the machine. The operator must push a button to deliver an electrical shock. Many use a computer voice synthesizer to advise the EMT which steps to take next, from one step to the next. Most AEDs are semi-automated. The advantages of AED use include the following. It's a quick delivery of electrical shock, easy to operate, there is no need for ALS providers to be on the scene, Remote adhesive defibrillator pads are safe to use. The larger pad area covers a larger pad area than manual paddles, which means the transmission of electricity is more efficient. Other considerations when using AEDs include the following. Not all patients in cardiac arrest require an electrical shock. All patients in cardiac arrest should be analyzed with an AED because sometimes their rhythm is not one that is a so-called shockable rhythm. And we're going to cover these briefly here. I mentioned asystole before, which is flatline, and indicates that zero electrical activity remains in the heart itself. A pulseless electrical activity usually refers to a state of cardiac arrest that exists but is disorganized in terms of its electrical complex. So, in other words, the heart literally sits in the chest, and if you were able to open up the chest and look at it, it would just be quivering. Early defibrillation is an essential intervention for patients experiencing cardiac arrest. Few patients who experience sudden cardiac arrest outside of a hospital survive unless a rapid sequence of events takes place. The links in the survival chain, or the chain of survival, include, number one, and you must know these completely and thoroughly. So the links in the cardiac chain of survival include the following. Number one, and in this order, recognition of early warning signs and immediate activation of EMS. Number two, immediate CPR with emphasis on high-quality chest compressions. Number three, rapid defibrillation. Number four, basic and advanced EMS care, and then advanced life support and post-arrest or post-cardiac arrest care. So these 5 links in the chain of survival in this order are essential to provide the best chance of treatment and recovery for your patient. Here's an illustration of the links in the cardiac chain of survival. So you recognize the first one, recognition and activation of EMS. Second link, immediate high-quality CPR. Third link, rapid defibrillation as soon as possible. Number 4, basic and advanced EMS care. Number 5, advanced life support and post-cardiac arrest or post-arrest care. CPR helps patients in cardiac arrest by prolonging the period during which defibrillation can be effective. Rapid defibrillation has successfully resuscitated many patients in cardiac arrest due to ventricular fibrillation. Defibrillation works best if it takes place within 2 minutes of the onset of the cardiac arrest. Non-traditional first responders are being trained to use AEDs. So, in other words, if your patient works in an office, it might be their company's policy to have AEDs on site, and everyone has had CPR and AED training. That would be a non-traditional first responder. That final step in the chain of survival is advanced life support and post-arrest care. In this step, the patient will receive continuing ventilation at less than 12 breaths per minute to achieve an EtCO2 level of 35 to 40 millimeters of mercury. Let me say that one more time. The patient will receive continued ventilation at less than 12 breaths per minute to achieve an EtCO2, that's carbon dioxide level, of 35 to 40 millimeters of mercury. The oxygen saturation will be maintained between 94 and 99%. Also, blood pressure needs to be assured to be above 90 millimeters of mercury, and then maintaining glucose level in a patient who is hypoglycemic is an important part of this care on this last link as well. This last link also includes cardiopulmonary and neurologic support at the hospital, as well as other advanced assessment techniques and interventions when indicated. When integrating the AED and CPR into patient care, keep the following in mind. It is important to work the AED and CPR in sequence. Do not touch the patient while the AED is analyzing the heart rhythm and delivering shocks. The CPR must stop while the AED is performing its job. AED maintenance is extremely important. Become familiar with the maintenance procedures required for the brand of AED that your service uses. Make sure to read the operator's manual. The 3 most common errors with certain AEDs in terms of their performance is the machine might not detect a fine ventricular fibrillation reading. In other words, the patient's in VFib, but it's so fine or faint that the machine does not recognize it very well or at all, and therefore doesn't shock. Another error that can occur in AEDs with certain AEDs is applying the AED to a patient who is moving, squirming, or being transported. The machine can't discern body movement from heart rhythms because obviously your muscles run on electrical activity as well. So it just can't discern body movement from the heart rhythm itself. Some models. Turning off the AED before analysis or shock is complete. Sometimes the power button is such that it's too easy to turn the machine off and not realize that it is still conducting analysis or is about to perform a shock. Some machines just don't have any kind of fail-safe built in to prevent you from doing that. Now, operator errors include failing to apply the AED to a patient in cardiac arrest. So going back to the beginning of the chapter when I was talking about how crucial it is to know anatomy and physiology and certain body systems well, this is a prime example. You must understand the circulatory system, what can affect it drastically, and how to recognize that a patient is in cardiac arrest. I mean, you need to be fully and completely aware of exactly what signals your patient's body is giving you. Another operator error includes not pushing the analyze or shock button when the machine advises you to do so. It seems improbable, but you may experience this yourself, or maybe have experienced it if you've already gone through AED training, is when learning, the responder will go through all the steps and follow all the machine's prompts, and when that orange button comes on or red flashing button and tells you to shock, the responder freezes and doesn't press the button. There are varying theories as to why that happens, but it can happen, and it is absolutely operator failure. Also, a common error, or one that can certainly happen, is pushing the power button instead of the shock button when shock button is advised. So know your equipment, read the operating manual so that you know which button to press. Usually it'll flash or have some kind of specific indicator, as far as shock now, but make sure, again, that you read the literature accompanying your device so that you know what to expect and you're pressing the correct button at the correct time. Also, maintain the battery properly and make sure it is properly charged and fully charged at all times. Check your equipment, including your AED, daily at the beginning of each shift, and then also, if need be, ask the manufacturer for a checklist of items that should be checked daily, weekly, or less often. If you're reviewing your SOPs, standard operating procedures, daily procedures, monthly, weekly, and you notice the absence of information relating to your AED units, and you can't find it anywhere, absolutely bring it to your supervisor's attention. But it may be that your service has to turn to the manufacturer for a checklist that instructs when and how often the device should be, or devices should be, cleaned and checked. Is that daily, weekly, or whatever specific time frame that they outline in their instructions. Report any AED failure that occurs while caring for a patient to the manufacturer and to the U.S. Food and Drug Administration. Be sure to follow the appropriate EMS procedures for notifying these organizations. Medical directions should approve the written protocol that you will follow in caring for patients in cardiac arrest. The EMT and your service's medical director or quality improvement officer should review each incident in which the AED is used. Quality improvement involves both the individuals using AEDs and the responsible EMS system managers. Reviews should focus on speed of defibrillation, such as the time from the call to the shock. Shocks should be delivered within 1 minute of the call. Mandatory continuing education with skill competency review is generally required for EMS providers. And let me clarify something. Back here, previously when I said that shocks should be delivered within 1 minute of the call, that means that the timing on the mechanism from the point of time where it recommends a shock to the time, and you call it, to the time the machine is ready to provide the shock, should be 1 minute or less. So if your machine is operating outside of that guideline, then that's what they're stating specifically there. So the other one that I wanted to make sure you're clear on is speed of defibrillation, time of call, time of shock, which I just reviewed, and actually that was the only one I wanted to clarify. Thank you. Next slide. Emergency medical care for cardiac arrest. When preparing to use an AED, it is the EMT's job to make sure that the electricity from the AED injures no one. Do not defibrillate patients in pooled water. Electricity will diffuse through the pooled water. We all know water conducts electricity. You can defibrillate a soaking wet patient, but dry the patient's chest and make sure that there is no pooled water underneath them. So if their clothes are dripping a fair amount of water and you've removed them from standing water source or pooled water source, use towels, sheets, etc. to soak up pooled water so that you don't come in contact with any that's dripping from them. So you can defibrillate a soaking wet patient, but dry the patient's chest and again make sure they're not developing pools of water around them. And do not defibrillate patients who are touching metal that others are touching. Carefully remove nitroglycerin patch from patient's chest and wipe the area clean with a dry towel before defibrillation to prevent ignition of the patch. We all know from watching old cowboy movies that nitroglycerin is highly volatile. So if you introduce electricity through a nitroglycerin patch, it's going to ignite. Now, if you bare a patient's chest and they have a patch on them, often the patch will have writing on it, but that writing fades over periods of time between administration to help the patient remember when it's time to put a new one on. However, many patches look similar, and if you don't know whether it's nitroglycerin or not, just remove all patches, and that way you're safe. Okay? Don't take the time during cardiac arrest to try to figure out what kind of patch they have on. Just take any medical patches off, clean the area, and proceed forward. Also, it is often helpful to shave a hairy patient's chest before pad placement to increase conductivity. Determine the patient's NOI and or MOI. Perform spinal immobilization for trauma patients during the primary assessment. Call for ALS assistance if you are in a tiered system with a patient in cardiac arrest. And then used a well-organized team approach. The figure on this slide displays the AED algorithm. In other words, these series of steps you should take. So please make sure to review this slide and be completely familiar with the AED algorithm. If you witness a patient's cardiac arrest, begin CPR starting with chest compressions and attach the AED as soon as it is available. You will practice this in Skill Drill 16-3, which covers the steps of using an AED. Follow local protocols for patient care after AED use. After AED protocol is completed, one of the following is likely. Pulse is regained, or there will be no pulse and AED indicates that no shock is advised. In other words, they've gone to a non-shockable rhythm. Or you might have no pulse and the AED indicates that a shock is advised, in which case they are in a shockable rhythm. If ALS is responding to the scene, stay where you are and continue the sequence of shocks and CPR. If ALS is not responding to the scene and protocols agree, begin transport when one of the following occurs. The patient regains a pulse, 6 to 9 shocks are delivered or as directed by local protocol, and the machine that gives 3 consecutive messages separated by 2 minutes of CPR that no shock is advised or as directed by local protocol. Cardiac arrest during transport. If you are traveling to the hospital with an unconscious patient and the patient loses their pulse or becomes pulseless, stop the vehicle, begin CPR. If the AED is not immediately ready, call for ALS or other available resources based on circumstances and local protocol. Analyze the rhythm. Deliver 1 shock if indicated and immediately resume CPR. Continue resuscitation according to local protocol. If you are en route with a conscious adult patient who is having chest pain and becomes unconscious, check for a pulse, stop the vehicle, begin CPR if the AED is not immediately ready, and analyze the rhythm. Deliver 1 shock if indicated and immediately resume CPR. Begin compressions and continue resuscitation according to your local protocol, including transporting the patient. Coordinate with ALS personnel according to your local protocols. If you have an AED available, do not wait for paramedics to arrive. Notify ALS personnel as soon as possible after you recognize a cardiac arrest. Do not delay defibrillation. When paramedics arrive, inform them of your actions to that point and then interact with them according to your local protocols. Management of return of spontaneous circulation. Monitor for spontaneous respirations. Provide oxygen via BVM at 10 to 12 breaths per minute. Maintain an oxygen saturation between 95 and 99%. assess the patient's blood pressure, see if the patient can follow simple commands. If an ALS is not on scene if ALS is not on scene or is en route, immediately begin transport to the closest appropriate hospital depending on local protocol. In other words, if they're not on scene, if ALS is not on scene, or they're on their way and you can't wait on them, immediately begin transport to the closest appropriate hospital depending on local protocol. So if ALS is not present or is too far away, not immediately available, then you need to immediately begin transport. Now let's do the review questions for this chapter. There's a lot to this chapter. So let's hit 10 review questions and see how you did. And make sure to make notes so you know what to go back and perhaps review more intensely on your own. Question number 1. All of the following are common signs and symptoms of cardiac ischemia except headache, chest pressure, shortness of breath, or anxiety and restlessness. If you remember your definitions and different types of cardiac conditions, you'll get this one correct. The correct answer is A. Cardiac ischemia, by definition, occurs when the heart's demand for oxygen exceeds available supply. Common signs and symptoms of cardiac ischemia include chest pain or discomfort, shortness of breath, which is dyspnea, and anxiety or restlessness. Headache is not a common sign of cardiac ischemia. So we said that the following are common signs and symptoms of cardiac ischemia except A, headache. Headache is not one of them. B, chest pressure is one sign and symptom of cardiac ischemia. C, shortness of breath or dyspnea is a response that you see in cardiac ischemia due to decreased cardiac output and hypoxia. And D, anxiety or restlessness, is caused by fear of death and is a result of hypoxia, decreased cardiac output, and ischemia. Question 2. While palpating the radial wrist of a 56-year-old man with chest pain, you note the pulse rate is 86 beats per minute and irregular. This indicates pain, fear, anxiety, or dysrhythmia. Let's look at the correct answer. This one should be pretty simple. And it is D. An irregular pulse in a patient with a cardiac problem suggests dysrhythmia, which is an abnormality in the heart's electrical conduction system. Patients with signs of cardiac compromise who have irregular pulse must be monitored closely for cardiac arrest. So to review the other answers, here's the question again, or scenario. When palpating the radial pulse of a 56-year-old man with chest pain, you note the pulse rate is 86 beats per minute and irregular. This indicates A, pain. Pain's not the correct answer because pain could be the result or symptom of cardiac ischemia. B, fear. That's not the correct answer because fear of impending death is usually the psychological result of having chest pain. C, anxiety. Anxiety is also a common symptom of a cardiac event, but in this case, the correct answer is D, dysrhythmia. Question 3. A 56-year-old man has an acute myocardial infarction. Which of the following blood vessels became blocked and led to his condition? Is it A, coronary vein, a B, coronary artery, C, is it a pulmonary vein, or D, is it a pulmonary artery? I talked about early in the chapter about knowing the anatomy and physiology, and even more specifically, building upon that, the anatomy and physiology of the cardiovascular system. So, knowing that, the correct answer should be straightforward. And it is B. The coronary arteries, which branch off of the aorta, supply the myocardium, which is the heart muscle, with oxygen-rich blood. Occlusion of one or more of these arteries result in a cessation of oxygenated blood beyond the area of occlusion and results in acute myocardial infarction, or AMI. It is important to note also that if you go back and look at the slide early in the chapter that illustrates the anatomy and physiology of the heart, you will notice that these branches off of the aorta, the coronary arteries, are literally like a five-fingered branch of fingers, literally, that go around the heart and supply different sections of the heart with its own blood supply. And so you can have one or more of these coronary arteries that feed the myocardium, or heart muscle itself, its own oxygen supply. So these coronary arteries are branched off the aorta, envelop the heart like a five-fingered glove, and feed different sections of the heart its own oxygen supply. And if one or more of these becomes blocked, then that section or those sections of heart muscle begin to die. And of course that can result in acute myocardial infarction or tissue death of the myocardium, which is the heart muscle itself. So let's look at the incorrect answers. The scenario again is a 56-year-old man who has acute myocardial infarction. Which of the following blood vessels became blocked and led to his condition? A, coronary veins. Coronary veins do not carry oxygen. They carry deoxygenated blood. So they would not be the direct cause of AMI. B, coronary arteries. That, again, that's the correct answer, as I just so thoroughly explained for you. C, pulmonary veins. Pulmonary veins are the primary blood supply to the lungs, not the heart. And D, pulmonary arteries, that's not the correct answer, because pulmonary arteries are the route of blood return to the left atrium from the lungs. An obstruction there would not cause an AMI. AMI occurs when one of those or more of those 5 coronary arteries that feed the heart muscle, myocardium itself, when one or more of those becomes blocked. That's when you have myocardial infarction. Question 4. Major controllable risk factors for AMI or acute myocardial infarction include A, older age, B, family history, C, cigarette smoking, or D, the male sex. We talked about different risk factors for different aspects of disease in the circulatory system, but the risk factors here, the most correct answer will be C, smoking. Smoking is a major controllable risk factor for cardiovascular disease. And if you recall, there are other like congenital factors, things that you can't control, that can also cause heart disease. But the answer here is C. Let's look at the incorrect answers. Major controllable risk factor for AMI includes A, older age. That's uncontrollable. B, family history. That's uncontrollable. C, cigarette smoking. That's controllable. D, male sex. That's uncontrollable. So that one's pretty straightforward. Question 5. A patient with cardiac arrest secondary to ventricular fibrillation has the greatest chance of survival if A, CPR is initiated within 10 minutes. B, oxygen and rapid transport are provided. C, defibrillation is provided within 2 minutes. Or D, paramedics arrive at the scene within 5 minutes. This one is extremely simple and straightforward. And all you need is simple logic here. I know you'll get this one right. And it is C. Survival from cardiac arrest secondary to ventricular fibrillation is the highest if CPR is provided immediately and defibrillation is provided within 2 minutes of the patient's cardiac arrest. Early, high-quality CPR and defibrillation are the two most important factors that influence survival from cardiac arrest. So let's look at our incorrect answers. A, CPR is initiated within 10 minutes. If you wait that long, their brain is completely dead. If you recall, during the slides or if you recall, study of the respiratory system, it only takes 4 to 6 minutes. Anything beyond that, I mean, when you get into the 4 to 6 minute range of the brain being without oxygen, irreversible brain damage has occurred, and or death at that point. So if you begin CPR 10 minutes, they're dead already. So obviously that's incorrect. B, oxygen and rapid transport are involved. Oxygen therapy and transport are important parts of resuscitation, but CPR and early defibrillation afford the greatest chance of survivability. And again, that's that 5 links in the cardiac chain of survival that I talked about. You can see them being prioritized here in why B is not the most correct answer. C, defibrillation is provided within 2 minutes. There's your correct answer. D, paramedics arrive at the scene within 5 minutes. Not necessarily. CPR and early defib or defibrillation will provide the greatest chance of survivability. Number 6, a 59-year-old woman presents with chest pressure. She is conscious and alert, but her skin is cool, pale, and clammy. Your first step in providing care or treatment should be A, apply the AED, B, administer oxygen, C, ask her if she takes nitroglycerin, or D, take a complete set of vital signs. So if you think about her state, she's conscious and alert, but she's showing signs of trouble. In other words, her skin is cool, pale, and clammy. So your first step should be one of these 4, and I'll bet you get it right without a terribly great effort. And it is B. Any patient with suspected cardiac compromise should be given oxygen as soon as possible. Don't put her through an increased risk chances of a bad outcome by taking a history or something like that. Give her oxygen. She's showing signs of oxygen compromise. Okay, so let me reread this entire answer for you. Any patient with suspected cardiac compromise should be given oxygen as soon as possible. And obtaining vital signs and inquiring about the use of nitroglycerin are appropriate, but you need to administer oxygen first. The AED obviously is applied only to patients who are in cardiac arrest. She's not, and hopefully she won't be. But the best thing you can do to prevent that at this point in time is give her oxygen right away. Number 6, a 59-year-old woman presents with chest pressure. She is conscious and alert, but her skin is cool, pale, and clammy. Your first step in providing care is, and we're going to review the incorrect answers here. A, apply the AED. Again, that's in patients who are only in cardiac arrest. B, administer oxygen. That's the correct answer. C, ask her if she takes nitroglycerin. Again, that is appropriate, but is not the first step. And D, take a complete set of vital signs. That's important, but again, not the first step. Number 7, if a patient with an implanted pacemaker is in cardiac arrest, the EMT should A, avoid defibrillation with the AED and transport at once. B, not apply the AED until he or she contacts medical control. C, place the AED pads away from the pacemaker. Or D, apply the AED pads directly over the implanted pacemaker. So let's look at the correct answer. It is C. The only modification of action required for cardiac arrest patients with an implanted pacemaker is to ensure that the EMT does not place the AED pad right on top of the pacemaker, but away from it. If you place the pad right on top of the pacemaker, it will result in a less effective defibrillation, and it may damage the pacemaker. And there's a good chance that if they're in this kind of situation, the pacemaker's not working already. However, if you put the pad directly over the pacemaker, the charge is going to go into the pacemaker, not into the chest and heart of the patient, which is your intention, of course. So let's look at the incorrect answers. In a patient with an implanted pacemaker is in cardiac arrest, the EMT should A, avoid defibrillation with the AED and transport at once. That's incorrect because AEDs can be used with pacemakers, but again, avoid placing the pads over the pacemakers. B, do not apply the AED until he or she contacts medical control. Well, you're trained in the use of AED, and lay people who are certified can use AEDs. So there's no reason for you to contact medical control. And this is part of your training right here, right now. And we're saying to you, once you achieve this certification, you will know that it's not necessary to contact medical control if they have a pacemaker. Just modify your action in where you place the pad. C is the correct answer, and we've thoroughly covered why that's the correct answer. D is incorrect when it states that you apply the AED pad directly over the pacemaker. We've covered that one as well. You're going to send the shock into the device, not into the chest of the patient. Number 8, the main advantage of AED is A, it provides quick delivery of a shock. B, it is easier than performing CPR. C, there is no need for ALS providers to be on scene. Or D, all of the above. And the answer is D, all of the above. The AED provides quick delivery of shock. It is easier to perform than CPR and does not require ALS providers to operate it. But there is one aspect that they left off of here, which I think is equally important for you to remember and consider. And that is that while all of these things are true, the most important thing is that the AED can help restore normal rhythm to the heart, while CPR will not restore rhythm. With CPR, all you're doing is continuing oxygenated blood flow delivery to the heart and vital organs, heart, brain, and vital organs. So let's look at the incorrect answers. And actually, there is no incorrect answer here unless you took one of these singly. So the answer again is D, all of the above, and we've pretty much covered it. And this is the rest of that question, and I'm not going to re-review anything here either. Moving on to 9. Number 9, after administering a nitroglycerin tablet to a patient, the EMT should A, check the expiration date of the nitroglycerin, B, reassess the patient's blood pressure within 5 minutes, C, instruct the patient to chew the tablet till it is dissolved, or D, ensure that the nitroglycerin is prescribed to the patient. This one should be very straightforward and easy if a couple of these didn't make you laugh. And it is B. Nitroglycerin is a vasodilator, and you can lower the patient's BP. Therefore, you should reassess their blood pressure within 5 minutes after giving the nitroglycerin, and it is dissolved under his or her tongue. It is a sublingual tablet. It should not be chewed. You need to obviously check the expiration date and the label of the prescription bottle matching that of your patient before administering the nitroglycerin. And since we've covered why A, C, and D are incorrect and B is correct, I'm not going to review the incorrect answers. It's all been covered right here. And again, we're not going to cover A, C, and D, and right here is B, the correct answer. And there's C and D, and we've covered why those are incorrect as well. Question 10. Nitroglycerin is contraindicated in patients with a systolic blood pressure of less than 100 millimeters of mercury, B, with chest pain of greater than 30 minutes of duration, C, who are currently taking antibiotics for an infection, or D, who are younger than 40 of age and have diabetes. remember what nitroglycerin does, and you'll see the obvious contraindication here. And it is A. Nitroglycerin is a vasodilator and may cause a drop in blood pressure. So, if it's contraindicated in a patient with a systolic BP, systolic being that top number, with a systolic blood pressure of less than 100 millimeters of mercury, or in patients who've taken erectile dysfunction or ED drugs within the past 24 to 48 hours. ED drugs are also vasodilators. So if given in combination with nitroglycerin, the result's going to be severe hypotension. And you're also going to get acute hypotension if their blood pressure is 100 millimeters of mercury or below. So you got more serious problems to address at that point. So let's look at the incorrect answers. A is correct. If they've got a low systolic blood pressure, do not give nitroglycerin. B, chest pain of greater than 30 minutes of duration. Well, cardiac chest pain is the primary indication for use of nitroglycerin. The patient may already be on nitroglycerin because they have chronic angina pectoris or angina. C, it's contraindicated in patients who are currently taking antibiotics. Antibiotics are not a contraindication for nitroglycerin use. Antibiotics do not have pressure, do not have an effect on the pressure within the circulatory system. So there's no reason for nitroglycerin to be an issue if they're taking an antibiotic. D is incorrect. It says for patients who are younger than 40 and have diabetes. While their age must be considered, their age is not a contraindication for use of nitroglycerin. Okay, class, this was another intense but obviously important chapter because 1 out of every 3 adult deaths in the United States is due to coronary problems. So, it is extremely important that you know this chapter very well, as this is going to likely be the vast majority of the calls you make on patients. So if you need any extra help, get a study group or ask for help with your instructor. Make sure to go back and review the tables and figures that were mentioned in this slide presentation and shown to you. Make sure to specifically know the structures in the heart and the structures of the electrical system in the heart. Thank you for your close attention, and we'll see you next class.